Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience in teaching undergraduate and postgraduate medical students, and I've done my MBBS and MD from Rajiv Gandhi University of Health Sciences. Today we'll be discussing about perinatal infections. So basically all this congenital rubella infection, toxoplasmosis, syphilis, cytomegaloviral infections, herpes infections, congenital HIV infections, tuberculosis. So these are the topics which we'll be discussing today. Before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform. There are a lot of benefits you can avail from this platform. Firstly, the daily live classes. So you can chat with your educator and you can attend these classes every day because a lot of educators in this platform, they do have regularly in this platform. So you can attend your favorite educators classes and engage in discussions, ask your doubts, and these questions will be cleared in the live chat box immediately. Okay. Also, whenever you're preparing for your entrance exam, you need to have a structured goals. Okay, all that means what you need to plan well. So you need to revise well beforehand for your entrance exams. So here in Unacademy, all these courses are structured in line with your exam syllabus, and this will help you a lot in your preparation. Also, whenever you're preparing for your entrance exam, you need to evaluate yourself. You need to know what is your strong area, what is your weak area, so that you can concentrate better on those weaker subjects. So here in this platform, there are a lot of quizzes and tests happening, and that is how you can evaluate yourself better. So all these quizzes are very important for your entrance point of view. So this is how you can evaluate yourself and you can concentrate better on these weaker subjects. So coming to the unlimited access. So once you subscribe to the subscription, you get access to all the classes in the subscription platform. Okay, even if you have missed a live class, you can go back and watch these recorded classes again and again. All this in the comfort of your home, in the comfort of your own devices. So I would highly recommend this platform. So using this platform in the beginning part of your preparation will help you a long way. Okay, so these are the top educators in this platform. They have regular classes happening. Do go and watch their classes too. And also all the 19 subjects which are required for your NEET PG preparation are taught in this platform. And these are the ongoing courses in our platform. So now coming to the NEET PG subscription, as you can see, the NEET PG subscription package varies from 1 month to 2 years, right? So I would suggest the 1 year and the 2 year subscription, and also the 6 month subscription for those students who are prepared. I mean, giving their 2021 NEET PG entrance exam. So the 6 months will cost you 20,000, but if you use my code Shilpa 10, you get a 10% discount and it will come up to 18,000. While the 1 year subscription is 25,000, using my code Shilpa 10, you get a 10% discount and it will come up to 22,500. And for the 2 year subscription, it is 30,000, but using my code Shilpa 10, you get a 10% discount and it will come up to 27,000. So I highly recommend this platform, and as you can see, the rates of this subscription are also very reasonable compared to other platforms. Okay, and there are a lot of educators you can choose to watch the class from. Okay. So today's topic, which is the intrauterine infection. So intrauterine infections are caused by a lot of microorganisms, right? There are viral infections, there are bacterial infections. So for example, there is an acronym for the intrauterine infections, which is called as TORCH. Okay, so T for toxoplasmosis. Okay. O is for other infections. There are a lot of infections which come under this. So I will talk about it next. R for the rubella infections. C for cytomegalovirus infections, H for herpes. So now coming to the other infections. So that could be HIV infection, it could be syphilis, it could be gonococcal, tuberculosis, it could be malaria, there could be varicella. So there are a lot of other congenital perinatal infections which happen. Okay, so now coming to the clinical infection. So now these children, the clinical features. So how do these children present? So first of all, they are normal at birth. Okay, so they maybe you might not even suspect this child could have a in perinatal infection, but as the days goes, they show one by one features. So viral infections in the early part of the pregnancy, they can cause fetal death, they can cause congenital malformation, or even severe systemic manifestation. So in the early part of the pregnancy, they can cause fetal death. So most of these intrauterine infections come in the first part, in the first trimester. Okay, so if it happens in the first trimester, the chance of congenital malformations are quite high than compared to the last trimester. So the incidence of these intrauterine infections is up to 0.5 to 2% of all live births. Okay, and cytomegaloviral infections and the rubella infection is the commonest of all the infections. Now, so there are certain pointers you need to keep in mind, which will have a high alert to suspect an intrauterine infection. So, if the presence of any of the three of the following should raise an alert in the pediatrician for the possibility of intrauterine infection. So, if there is any maternal history of infection, so as when you also should know when you in your OBG classes, in your clinical clinics, so we always ask if the mother has a history of fever. Also in the pediatric clinics, you should ask all these maternal history, right? So if there's history of fever, if there's history of fever with rash, if there was hepatomegaly, lymphadenopathy, if there was jaundice. So this is because it gives a clue in the child that it could be a intrauterine infection. Okay, so that is why that is very important. So especially in other condition is like where there is genital herpes. So genital herpes, if the mother has genital herpes during the time of delivery, the mother can transfer the infection to the newborn. That is why this maternal history of infection is very important. Okay, next coming to the intrauterine growth retardation. So if the child is born with intrauterine growth retardation, first of all you need to know why these children have intrauterine growth retardation. So one of the main cause could be torch, but there are other conditions also, like poor socioeconomic status, maternal health, maternal nutrition of the maternal nutrition, placental insufficiency. Okay, if the mother has chronic illness, so if all these conditions are ruled out, then you should always think in the last thing, you should always think about intrauterine infection. If the mother has, okay, if the mother had chronic infection, if there's some kind of placental insufficiency, if there was eclampsia, then okay, there is still a cause. But there is no cause, but the child is still having intrauterine growth retardation, you should think about it. Okay, so the next is hepatosplenomegaly. So most of the intrauterine infections do have hepatosplenomegaly. Okay, so that again should ring a bell in us. Next is jaundice. Okay, petechiae and purpura. So most of these have certain kind of I mean each disease has a different kind of rash. So when a child is born with petechiae or purpura, it might give you a clue. Meningoencephalitis. So as the infection increases in the body, the child might be present with meningoencephalitis. Okay. Next is radiological abnormality. So radiological abnormalities is what? So in certain infections there is calcification of the brain. So there is cerebral calcification, and in some children there could be limb skeletal what is it, changes. Okay, so that is why in these children, if you like the child is IUGR, okay, and there could be petechiae and purpura. Okay, you think, okay, fine, let us just think if this could be an intrauterine infection, you need to get a ultrasound of the cranium, or an CT, MRI, or a infantogram, just to see if there is any kind of abnormality. So radiological abnormalities have to be kept in mind. And another thing is raised IgM in the cord blood. So IgM does not cross the placenta. So if there is IgM, okay, if for a particular disease, then so if it's IgG, it crosses the placenta. But if there is IgM in the cord blood or in the neonatal blood, then you have to have a suspicion. So any cord level of IgM more than 20 milligram per DL should indicate a fetal infection. Okay, so this is what you need to know. So now coming to congenital rubella. So in congenital rubella, so now if you're making notes, divide your page into the disease, name of the disease, and then you write IUJ. So make a chart like this. Okay, because all of this will have a similar. Okay, so this is the disease, IUGR, hepatosplenomegaly with jaundice, petechiae and hemorrhage, ophthalmic signs, neurological signs, and others, so that it will be easier for you when you revise. Okay, so make notes like that. Okay, keep enough sufficient space for you to write. Okay. So now a child with rubella, congenital rubella. So if the mother has rubella, history of rubella, huh, okay, how do they present? So they can present with IUGR. So around 60% of the children who are infected perinatally by rubella can have IUGR. Another important thing is hepatosplenomegaly and jaundice. Okay, so hepatosplenomegaly and jaundice can be present in 60 to 70% of children. Okay, there also could be petike and purpura. Okay, so as I've told you, IUGR, hepatosplenomegaly and petike and purpura are very common in intrauterine infection. Next comes the ophthalmologic features. So here, cataracts, rubella children, cataracts, microphthalmia can be there, corneal opacity can be there, and glaucoma can be there. Okay, the chorioretinitis picture has a salt and pepper type of picture, type of chorioretinitis. Okay, so remember the congenital rubella, the chorioretinitis picture is like that of a salt and pepper appearance. Okay, so these children can eventually have meningoencephalitis, they can have deafness. Microcephaly is rare. Okay, but microcephaly can be there, but it is rare. So what are the congenital cardiac defects? So rubella children will have certain cardiac defects. The most common associated cardiac defect in rubella is PDA. Okay, other than that, there could be pulmonary artery stenosis, there could be aberrant subclavian vessels, it could be a VSD. Okay, and when you get a radiology of the limbs, there will be metaphyseal changes. Okay, in the long bones there could be linear areas of translucency. Okay, it will be white, so there'll be lines in the long bones. Okay, and there'll be increased density. Okay, so the translucency will be black. So another important thing, you should know the triad of congenital rubella. There's a triad. So one is cardiac defects, next is cataract, and finally it is the deafness. So this is a triad of a child with congenital defect. So if the child has cataract, if there is also deafness and a cardiac defect, you should think about congenital rubella. So now how do you diagnose this child? So when a child is born, okay, maybe at birth you were not able to detect. So eventually this, you observe this child, you examine this child. So this child could have IUGR, you can see hepatosplenomegaly, you can see certain purpurae. So that time you would want to get a diagnosis. So if this child is could be because of rubella. So if you demonstrate the presence of rubella IgM in the blood, cord blood or in the neonatal blood, then you clinch the diagnosis of congenital rubella syndrome. There is no treatment. So there is no treatment for congenital rubella syndrome. So remember that. Next, so when in the first trimester, if you have a diagnosis of rubella in the mother, it is an indication to terminate the pregnancy. Because as you know, there are a lot of congenital malformations which can happen in the child, and another thing is there is no treatment for it. So that is why it becomes an indication for termination of the pregnancy if you are able to diagnose rubella in the mother. Fine. So now coming to cytomegalic inclusion disease. Okay, the cytomegalic inclusion disease. So in cytomegaloviral infection in the newborn, so when the newborn is born, there is IUGR. So IUGR is seen in 60 to 70% of children, and there is hepatosplenomegaly about 2/3 of the children. Okay, that means around 65-70% of the children have hepatosplenomegaly. So these children have certain petechiae and purpura. These petechiae and purpura are called as blueberry muffin spot. So remember this. This is a very important question. It is called as blueberry muffin spots. So why is this blueberry muffin spots in this cytomegaloviral infection? So this blueberry muffin spot is because of the extramedullary hematopoiesis. Okay, this occurs because of extradural hematopoiesis. Fine. So this is how. So remember for blueberry muffin spots. Okay. Next, so when you get when you get a retinal picture, you can see chorioretinitis. Okay. So the chorioretinitis presents as a cottage cheese with ketchup. type of appearance. Cottage cheese with ketchup type of an appearance. So this how it happens. So there will be diffuse white perivascular infiltrates. Okay, so there is diffuse white background. In between that there will be hemorrhages. So that is why cottage cheese, that is paneer. Paneer is white, right? So cottage cheese with ketchup appearance. Okay, so that you should remember, that happens with cytomegaloviral infections. Over here there is sparing of the macula. Okay, there could be microphthalmia in these children. So I'm talking about the ophthalmologic features in these children. So there could be microphthalmia, there could be uveitis, there could be optic atrophy. But remember about the blueberry muffin spots and the cottage cheese with ketchup type of chorioretinitis. Next, coming to strabismus. Okay, next feature is strabismus. So these children have strabismus, roving eyes. So basically, since they have so many ophthalmologic features, their vision is not so good. So they have this wandering eyes. They try to see everywhere. So that is called as roving eyes in infancy. Okay, so these children have strabismus and they also develop roving eyes in infancy because there will be visual impairment, and as a result they're not able to see well and they have this wandering eyes happening. Next comes to microcephaly. So as you saw, rubella does not have uh, that commonly microcephaly, but in the cytomegaloviral infections they will present with microcephaly. When you get an ultrasound, okay, through cranial ultrasound, or if you get an MRI or a CT, you will see that there is periventricular calcification. Okay, periventricular calcification. There could be motor retardation, psychomotor retardation. So other findings what you see in these children is there could be anemia, there could be interstitial pneumonia, there could be sensory neural deafness. The sensory neural deafness was also in rubella. Okay, that is why I've told you make a chart of this infection so that it will be easier for you to revise. Fine. So now coming to the treatment. So to treatment for this is ganciclovir. This is a parenteral IV treatment. IV treatment. Okay, so first of all you give, okay, there is an induction phase and a maintenance phase. So first you give an induction phase of 5 mg per kg per dose twice daily for 2 to 3 days. Then you do a maintenance, you give a single dose of 5 mg per kg per day, a single dose that you give for 8 to 12 days. So there is an induction phase which is for 2 to 3 weeks, followed by a maintenance phase. So that is for 8 to 12 weeks, right? Yes. Now, this ganciclovir has high adverse effects. So another thing is we have to weigh the risk. Is the child giving ganciclovir to this child, will it really help? Okay, if sometimes what happens, if the features and symptoms are so severe in the child, it will only worsen the condition. So you always have to weigh. Okay, so the side effects include there could be renal failure, there could be thrombocytopenia, the child can have testicular atrophy. Okay, that is why you have to do a regular renal monitoring. You have to get blood counts and platelet done. If the platelet counts falls below 25,000, if the platelet count goes below 25,000, or if the neutrophil count goes below 500 per millimeter cube, then you have to stop ganciclovir. Okay, now there is another alternative which is a oral van-ganciclovir. Okay, you can give oral form of this and it is quite helpful. Okay, yeah, this is used in the prophylaxis as well as the management. Next, coming to congenital toxoplasmosis. So congenital toxoplasmosis, so the maternal primary infection, uh, one second. Yeah, so the whatever the mother has, the maternal primary infection is generally subclinical, but this can lead to fetal infection. So this can mother can still transfer the child to have fetal infection. Okay, now the transmission of this disease increases with the advanced stage, but the risk of fetal disease decreases with the advanced stage. So now if if the fetus gets the infection in the first trimester, the risk of the fetal disease, the seriousness of the fetal disease is more in the first trimester compared to the third trimester. Okay, so now coming to the clinical features. So these children again have IUGR, but not as much as rubella and cytomegalovirus. So here it is up to 20 to 30%. There is hepatosplenomegaly also. There is Pediatrics and Perinatal also. Then there is central destructive chorioretinitis. Central destructive chorioretinitis. In the this thing it was peripheral chorioretinitis, right? And rubella. Next, there could be optic atrophy, there could be cataract, there could be uveitis, there could be hydrocephaly, or there could be microcephaly. There could be diffuse nodular cerebral calcification. So tell me where else you see periventricular calcification? So periventricular calcification is seen in CMV infection. Diffuse nodular cerebral calcification is seen in congenital toxoplasmosis. These children can also have strabismus, nystagmus, and visual impairment during infancy. Now, the treatment. So now the treatment of toxoplasmosis, so whatever drugs which are available, they act only on the tachyzoid forms. Okay, they do not end. They do not eradicate the uh, encysted forms. They do not eradicate. Okay, so now the drug, if the mother is positive for a toxoplasma infection, then you have to give spiromycin throughout pregnancy, and then when the mother is at the 20 weeks of gestation, you have to add sulfadiazine and pyrimethamine. So you start with spiromycin throughout the pregnancy, okay, from the start till the time of delivery. Then at the 20 weeks of gestation, you have to also add sulfadiazine and pyrimethamine. Now coming to congenital toxoplasmosis. So now the treatment of congenital toxoplasmosis is for a year. Okay, so you first start with pyrimethamine. Okay, and then pyrimethamine and sulfadiazine. So both you have to give for 6 months. Then you add pyrimycin for alternate days for another month during the next 6 months. Alternate days you should give. This pyrimethamine, whenever you give pyrimethamine, you should always supplement with folic acid. Also, corticosteroids can be added if there is severe fetal infection. Okay. Yeah, so you should remember, so the drug of choice in a pregnant mother, first you give spiromycin and then you give sulfadiazine. Okay. Now coming to congenital syphilis. So congenital syphilis is the maternal infection. So it's the only maternal infection which is associated with the recurrent abortions. Okay. Now this is transmitted throughout pregnancy. So certain pathognomic features you need to know. Okay. There is skeletal lesions. What are the skeletal lesions? So there could be craniotapes. There could be or periostitis, osteochondritis in these children. Then there is snuffles. So snuffles is called as syphilitic rhinitis. Okay, so basically these children have runny nose, and they will be what is it, in the secretion there will be trypanoma pallidum. So the syphilis is caused by trypanoma pallidum, right? So the secretion in snuffles will have trypanoma pallidum. What is called as pneumonia alba? So in pneumonia alba, the lungs will be pale and firm. This is because of the fibrosis happening. So that is why the pneumonia in syphilis is called pneumonia alba. Okay, and there are a lot of skin lesions happening. So there could be bullous skin lesions in congenital syphilis. Okay, what are the delayed features? So as the child grows, there could be a saddle nose, that is the depressed nasal bridge. Okay, so these children can have depressed nasal bridge, and the central incisors might be notched. So there is a notched central incisors, which is also called as Hutchinson's teeth. Remember, okay, so in congenital syphilis, the delayed features are depressed nasal bridge, Hutchinson's teeth. There could be keratitis. There's something called as saber shins. Okay, also there could be frontal bossing, and then there is something called as Clutton joints. So Clutton joints is basically there is synovitis with effusion in the uh, with joint effusion. Okay, so the most common area to happen for Klappen's joint is the knee. Other than that, it can happen in the ankle, it can happen in the elbow, it can happen in the wrist, it can happen in the fingers also. So remember Klappen's joints. So there are certain names you need to remember. So there is something called a syphilitic rhinitis or snuffles. Then there could be pneumonia alba, there is Hutchison's teeth, then there is Sabre shins, there is craniotips. But craniotips can happen in so many other conditions like rickets, there could be hypothyroidism, right? Okay. Then you need to know, remember about Klappen's joint. So these are the very important features you need to know about congenital syphilis. So when we come to the IUGR is very uncommon in these. Okay, meningoencephalitis can occur, deafness can occur. So the diagnosis of this is by a VDRL estimation. So when you get you do a VDRL and you check, compare it with the mother's estimated result. Okay. Also, a CSF analysis is a compulsory thing in a child when the child is born to a mother with syphilis. Okay, and the treatment includes procaine penicillin. Yeah, it is procaine penicillin, and if the procaine penicillin is not available, you can go for ceftriaxone. So this is the treatment for syphilis. Fine. So this was about congenital syphilis. Now coming to herpes. Okay, so usually this occurs during the time of delivery. Okay, if the mother has primary genital lesions. Okay, mother has primary. So another thing is this can present either as an asymptomatic infection or it could have become a fulminant infection. Okay, so remember the mother should have a genital lesion at the time of delivery. Okay, that is how the herpes infection is transferred to the child. So this could be in three forms. One is the skin can be affected, and then there is eyes and mouth which is involved, and the CNS also, like there could be meningitis and encephalitis. So these two also have skin lesions. Okay, yeah. So and these two conditions are more the serious forms. Okay, and so when you get how do you diagnose? So when there is a child with a vesicular rash, you have to confirm it. Okay, so first thing is, by one is you can get a Zank smear of the skin lesion and you can culture this skin lesions. You can get a PCR of the lesion or the CSF. There is no such serological diagnosis for herpes. Okay, the treatment is acyclovir. You give a 20 mg per kg per day of acyclovir in these children for 10 to 14 days. And then you have to again repeat the CSF PCR and check for the improvement or worsening, or it is status quo. Okay. So next comes the perinatal HIV infections. So perinatal HIV infections. One second. Yeah, so the perinatal HIV infections occur here. About 80% of the HIV infections in children occur during perinatal period. So in the children, 80% is because. So out of this, so most of the time, the transmission to the from mother to child occurs by 25 to 35%. Out of this, 30% is vertical transmission. Okay, there is 10 to 15 transmission percent can transmit by the breast milk. Okay, so now coming to the yeah, so as you all know how a child with perinatal HIV can present. Okay, they are in a immunosuppressed state, they can have recurrent infections and all this. So at the time of birth they'll appear normal. Okay, so that is why we have to evaluate this child and check for the serum levels of the antibodies against HIV to check how much is the disease in this child. So now what is an approach to the treatment of this child? So now if the baby is born to an HIV infected mother. Okay, now you have to get HIV PCR at 6 weeks, right? Also, you have to before that, at any child who is born to a mother with HIV, you have to start with the treatment. So you start with nevirapine. Okay. uh, if the mother has taken antenatal and intrapartum, or intrapartum means the time she had labor pains till the time the delivery of placenta. So if the mother has taken antiretroviral therapy, then nevirapine alone is enough. But if the mother has just taken intrapartum therapy, that time you have to give nevirapine plus zidovudine, and if the child is high risk, you have to give cotrimoxazole also. That is at 4 to 6 weeks. Okay, so as you, what did I say? So when a child is mother is infected with HIV, you start with nevirapine. Okay, if the mother has not received antenatal therapy and she's received only intrapartum therapy, antiretroviral, you give nevirapine and zidovudine. And in high risk children, you have to start cotrimoxazole at 4 to 6 weeks. So now, who are these high risk children? So who are the mothers who have received less than 4 weeks of antiretroviral therapy, less than 4 weeks of antiretroviral therapy, and mothers who have high viral load. Okay, then mothers who have received, I mean, who would have got infection during the time of delivery or during lactation or breastfeeding. Mother who would have got the infection during delivery or the during pregnancy or during breastfeeding, and mother first identified during the postpartum period. Okay, prenatally the mother would have been negative, but postpartum you would have found out that the mother is positive. So these are the high risk conditions where you also add cotrimoxazole. Okay, so now you need to know. Yeah, so at 6 weeks you have done this HIV PCR, right? So now you have to know it is positive or negative. So if it is positive, you send a whole blood sample for another HIV PCR. Okay, if this is negative, you continue the cotrimoxazole. Hello, Ravi. And you stop. This is should be given for 6 weeks, and then you stop nevirapine at sorry, at 6 weeks. Stop at 6 weeks. Yeah. Next, so this is positive, right? So now again you get an HIV PCR. So again, if it is positive, you should continue cotrimoxazole, and then you should start on the proper antiretroviral therapy. Okay, and you have to continue breastfeeding. Do not stop breastfeeding. Okay. Next, if the negative, then nothing to worry. You can continue. Continue cotrimoxazole and stop all antiretroviral therapy. Okay. So now, say here the child is on cotrimoxazole, but you have stopped nevirapine. So now at 6 months, you repeat HIV CR. Okay, if the child is symptomatic, then if it is positive, you should start the antiretroviral therapy. If it is negative, you uh, continue cotrimoxazole till 1 year. Okay, then slowly, gradually after that, 1 month later, you stop. Okay, then in these children, you have to repeat PCR after 6 weeks. Okay, then establish a definitive diagnosis at 18 months by HIV antibody test. So this is how you do. So we'll repeat this again. If I want to again tell this, so we'll clear this. So now a baby is born. Baby is born to a mother with HIV, right? So now what you do? You get a HIV PCR at 6 weeks. Before that, you start with nevirapine. Nevirapine. Okay, in high risk patients, you start with nevirapine plus zidovudine. And also you have to add for all these children cotrimoxazole. Okay, so now the HIV PCR at 6 weeks which you have done has come positive, right? So when it comes positive, you again repeat with the whole blood sample. So HIV PCR is repeated. It again comes positive. So if it comes positive, it continue cotrimoxazole. Okay, start on antiretroviral therapy, continue breastfeeding. Okay, now this is negative. If it is negative, what you do? You continue cotrimoxazole, okay, and stop nevirapine at 6 weeks. Next, at 6 months. Now at 6 months, so you have to get it regularly checked because you shouldn't miss these conditions. No, 6 months you again get a HIV PCR. Okay, now if the child if the child becomes symptomatic and if it is positive, you start on antiretroviral therapy. If it is negative, okay, you continue cotrimoxazole for 1 year and then gradually stop. Okay, then then you at 18 months you get HIV antibody test to confirm properly that this child has no HIV, congenital HIV. Next, in this state, so there is no symptoms, nothing. At 18 months, directly you get HIV antibody. But if you should repeat HIV at 6 weeks if you stop breastfeeding or if the child develops any symptoms. So after 1 year, now if anywhere in between that, if the child has any symptoms, you get an HIV PCR done. Okay, so here if again it comes positive, you should start with antiretroviral therapy. So this is not a very simple disease. This is a disease which affects the immunity and you'll be severe immunosuppression, and these children will have repeated infections. That is why you can't take it lightly. So there are a very specific intervals where you have to check it again and again. So one is at 6 weeks, then it is 6 months, then it at 1 year, then it is at 18 months. Okay. Fine. So now coming to congenital tuberculosis. So now congenital tuberculosis, one thing. Now, if the mother has a severe tuberculosis during pregnancy, there are chances that the child can develop tuberculosis. So when a child is born, you have to check for any symptoms, get an X-ray, chest X-ray to see for features of tuberculosis. If the child is diagnosed with tuberculosis, then you have to get the 2-HRZE plus 4-HRE. So this is what you have to give. So I have told in yesterday's class in the subscription about not yesterday. No. Yesterday I was talking about tuberculosis, right? Yesterday's class. So if it is divided into right now the pediatric categories are divided into just two categories. One is category 1 and category 2. So category 1, any fresh pulmonary tuberculosis is diagnosed as category 1, and even the treatment drug treatment has also been changed. So now for category 1 it is 2-HRZE plus 4-HRE. Okay, so another thing, if the child has no symptoms of tuberculosis, the chest X-ray is fine, it is enough to give just isoniazid prophylaxis. Okay, this should be given for 6 months. This you should know. So this is about congenital tuberculosis. Yeah, so this is how you manage, and so we'll have a quick revision now. Okay, so I have talked about all of the main congenital perinatal infections. So I have talked about congenital cytomegaloviral infection, congenital rubella syndrome, congenital toxoplasmosis, congenital syphilis, congenital herpes, congenital HIV infections, perinatal HIV infections, and congenital tuberculosis. So basically you have to, this is a very important topic because there are certain very specific signs and symptoms in these illnesses, and that could be asked as your questions in your NEET PG, and you should not confuse yourself. That is why make a chart and write down the specific pointers for each illness so that you will be able to revise better. Okay, and it will be there, so the all the illness will be in one page, in one chart, so it will be easy. The entire topic of congenital and perinatal infections will be done with one just rapid read, right? So that is why. So now coming to congenital rubella, so what important thing I've talked about, this is the triad for congenital rubella syndrome that you need to know is cardiac defect. There's a cardiac defect, there should be cataract and deafness. The cardiac defect, the most common is PT. Okay, and the chorioretinitis in congenital rubella syndrome is called as, is it salt and pepper type of chorioretinitis. Okay, so this you need to remember, and there is no management for rubella, congenital rubella. So if there is any in a pregnant woman in the first trimester, if you diagnose an unequivocal diagnosis of rubella is done, it is an indication for termination of pregnancy, because rubella can cause serious congenital malformations, congenital defects, which can hamper the life of the child. Okay, fine. Next, coming to cytomegalic inclusion disease. So now in over here, IUGR is very prominent. It is in 60 to 70% of the patients. Hepatosplenomegaly is also very prominent. The next important thing, there is Pediatrics and purpura, which is seen as blueberry muffin spots. So tomorrow there is a quiz. I will be showing certain images and I want you all to answer the questions. So tomorrow I see that most of my questions will be, what is it, image based, because I have taught you all one entire week of infections. So all these infections come with certain rashes. So tomorrow's quiz, most of the question will be based on the images, and I hope you all are ready for the quiz tomorrow. Fine. So in congenital inclusion disease, there is blueberry muffin spots. Okay, this occurs because of the extradural extramedullary hematopoiesis. Next, there is cottage cheese with ketchup type of peripheral chorioretinitis. Remember, there is peripheral chorioretinitis, which is a cottage cheese with ketchup. So there is a pale retina where there is hemorrhage happening. Okay, so that is why it looks like cottage cheese with ketchup. Okay, this pairs the macula. These children can have microphthalmia, they can have uveitis, atrophy, and another thing is that there is a roving eyes in this. So remember this, there is this roving eyes of infancy. So why roving eyes? So basically they have visual impairment and the eye is always wandering, they are not able to see properly. Fine. Next, and another very important thing is the microcephaly will be there in cytomegalic inclusion disease, and also the periventricular calcification that you need to keep in mind. The treatment is ganciclovir, but there are a lot of side effects for ganciclovir, so you should always weigh the situation whether to go ahead or not. Now there is also oral valganciclovir also given. Okay, so next, there are a lot of side effects for ganciclovir. So there could be renal failure, there could be thrombocytopenia, there could be testicular atrophy also. Congenital toxoplasmosis. Over here, you need to know that these children can have hepatosplenomegaly, IUGR, Pediatrics, purpura, but a very important thing, there is central destructive chorioretinitis. Okay, there could be optic atrophy, there could be cataract. These children can present with hydrocephalus or microcephalus. Okay, and there could be strabismus, nystagmus, and the calcification pattern over here is there is diffuse nodular cerebral calcification. Fine. Now coming to the treatment. So now whatever treatment drugs which are available for toxoplasmosis, they only act on the tachyzoid form. They do not eradicate all these encysted forms of toxoplasma. Okay, so the drug, so the toxoplasmosis is caused by Toxoplasma gondii, right? You remember? Fine. So the drug which is given, so in the antenatal period, if the mother is diagnosed of toxoplasma, you give spiromycin. That spiromycin should be given throughout the pregnancy, which is added with sulfadizine and pyrimethamine after 20 weeks of gestation. Next, when there is a child which is born with congenital toxoplasmosis, this treatment lasts for 1 year, right? Pyrimethamine and sulfadioxine is given for 6 months. Along with that, after the next 6 months is added with pyrimethamine. You give an alternate dose. So, along with pyrimethamine, you give folic acid, and in severe conditions of toxoplasma infection, you give corticosteroid. Next, coming to congenital syphilis, so you should remember congenital syphilis is one of the maternal infections that is associated with recurrent abortions. Okay, so this syphilis, if the mother has syphilis, that can be transmitted throughout the pregnancy. So you should, and a syphilitic child can present. They have very peculiar presentation, so you need to know the pathognomic features. So they have skeletal features, they can have craniotypes. So craniotypes is what? This is softening of the skull bone. So when you press over the skull bones, you can actually indent it, and when you remove it, like a ping pong ball, it will come back to the normal position. So that is what, that's craniotapes. There could be periostitis, there could be osteochondritis, there could be snuffles. Snuffles is nothing but syphilitic rhinitis. Is pneumonia alba, bullous skin lesion. Okay, so what are the delayed features? So as a child grows, a child can have Hutchinson's teeth. What is Hutchinson's teeth? There's a notched central incisor. Okay, there could be Clutton's joint. So basically it is Clutton's joint is nothing but synovitis with joint effusion. Okay, there could be frontal bossing, saber shins. Okay, so diagnosis is by VDRL estimation, and you compare with the maternal serum levels. Okay, and also a CSF analysis is very important. Treatment is by procaine penicillin, and if procaine penicillin is not available, you can go for ceftriaxone. Herpes. So when a mother has genital lesions at the time of delivery, that can transmit herpes to the newborn. Okay, so this can be a, it can, what is it called, a range from an asymptomatic child, or it could be a fulminant. Spectrum can be between asymptomatic herpes infection to a fulminant disease. So there are three forms which you should know. One is the skin infection, one is one herpes infection is at the skin, other could be because of involvement of the eyes and the mouth, and thirdly it could be the CNS involvement. But the eyes and the mouth, and along with CNS, also have skin lesions. Okay, but they are the more serious forms. The diagnosis is by Zang smear of the skin lesion, culture of the skin lesion, or the PCR of the lesions, or the CSF. Treatment is acyclovir. Okay, so HIV, as I've told you, so this is very important. You have to know this because again a clinical scenario might come. Okay, you have to know this. This is how. So when a child is born with HIV, you start with nevirapine, and in high risk children you put also zerovitin. Along with that, you have to give a cotrimoxazole prophylaxis. Okay, that is started at 6 weeks. Now at 6 weeks you do an HIV PCR. Okay, if it is positive, you have to repeat and again confirm it. If it is positive, because see, the thing is, these antiretroviral drugs have high side effects, right? So you have to confirm perfectly before starting the antiretroviral. That is why once at 6 weeks, and then again an HIV PCR is done, and again if it is positive, you should start you should continue with cotrimoxazole prophylaxis, because cotrimoxazole prophylaxis is given so that because of the immunosuppression, there could be a lot of infections happening in these children. That is why cotrimoxazole prophylaxis is given in these children. Okay, so also you start with antiretroviral therapy, and you should continue breastfeeding. Next, if the HIV PCR is negative, you continue with cotrimoxazole, but you can stop nevirapine at 6 weeks. Okay. Next, again repeat at 6 months. If that comes positive, you start with antiretroviral therapy. But if it is negative, you continue cotrimoxazole for 1 year, and then slowly after 1 month stop it. At 18 months, irrespective of presence of symptoms or not, get an HIV antibody tested, and that comes negative, then the child is diagnosed not have HIV infection. But during that period, if the child has any kind of symptom, you have to get an HIV PCR, and if that comes positive, you have to start on antiretroviral therapy. So this is how is a child with HIV infection treated. Next, coming to congenital tuberculosis. So if the child is positive for congenital tuberculosis, that is chest X-ray finding, you have to start with 2-HRZE plus 4-HRE. Okay, read the recent pediatric guidelines for tuberculosis. Okay, there are a lot of changes. I've told yesterday in the class. Okay. Next, if the child has no features of tuberculosis, the chest X-ray is fine. You still have to start on isoniazid prophylaxis for 6 months. Okay, so that the child should not be getting any kind of infection later. Okay, so this was today's class. So tomorrow will be a quiz on the entire pediatric infections. So please attend tomorrow's class. It will be a revision for the entire pediatric infections. Okay, so it will be a very helpful class. You will be able to revise. So if you all have not attended my previous classes, attend all those classes, all the infectious diseases class, so that tomorrow's quiz will be helpful for you all. Okay, so tomorrow's quiz will be mostly an image based question. I'll try to get some clinical scenarios. So tomorrow's quiz will be this. Also, and this is at 1 p.m. Also in the subscription platform tomorrow at 4 p.m. That is not a special class, it is on the subscription. I will be giving a class on resuscitation of the newborn. Resuscitation of newborn, with also I'll be teaching about perinatal asphyxia. Okay, okay. And yesterday's class, in the subscription, I had taught about the introduction to neonatology. All the normal newborn definitions were taught. So give a look at that class too. Okay, and coming to the subscription, so if you're subscribing to the subscription, use my code Shilpa10 and you'll get a 10% discount on the subscription. Okay, so good luck, do well, study daily. So this revising, studying daily is a must, and you have to keep yourself motivated. Talk to your friends, discuss topics with them. That will be some kind of a relaxation for you, and also it will help you to revise better and keep in mind the topics better. So discussion is a very important. Keep 1 hour of discussion and do not do any other gossip talking. So just do about the class. It will be very interesting. So when you all are discussing, okay, so good luck, study well.